Welcome to tonight's webinar, Application of Systematic Instruction Principles for Training Use of AAC in Adults. My name is Kevin Williams, and I am your facilitator for this evening's webinar. Tonight's program is brought to you by the United States Society for AAC, or USAC, the voice of AAC. Thanks to the USAC Education Committee and to Isaac for making this possible. USAC is thrilled with the response to tonight's Errorless topic. We had a lot of people registered. We hope you will join USAC by going to www.usac.org/membership. We hope you will join USAC by going to www.usac.org/membership. Our new membership year will begin January 1, 2019. Early registration for our webinars is a member benefit, especially helpful when our webinars are very popular this one. Another member benefit is a substantial reduction in registration for the biannual Isaac Conference this year in Gold Coast. Go to www.isaaconline.org to learn more about this fabulous opportunity. Go to www.isaaconline.org to learn more about this fabulous opportunity. Disclosure: I have no relevant financial or non-financial relationships to disclose relevant to the content of the webinar. Logistics. Your microphone will be muted. You can ask questions by typing into the question box in the lower right-hand corner of your screen. Questions will be answered as time allows in the last segment of the webinar. We may group together questions that are similar. We ask that you pose your question in a general fashion rather than related to a specific individual. Questions that are not responded to during the webinar may be answered afterwards via email. Continuing education, the ASHA CEU participant form and certificate of attendance can be found at www.isaaconline.org/English/news/webinars. who must stay for the duration of the webinar in order to receive credit. A circumflex URL and our webinar platform lets us see who is on and for how long. Registrants will receive a follow-up email that provides the link to the archive, CEU form and instructions. There is no charge to USAC members for ASHA SUVs. SUVs are $25 for non-members. At the conclusion of tonight's webinar, our speaker, presenter, Aimee Mooney, M.S. CCC-SLP, has practiced At the conclusion of tonight's webinar, our speaker, presenter, Aimee Mooney, M.S. CCC-SLP has practiced as a licensed speech and language pathologist for over 28 years. She has specialized in applying communication and cognitive rehabilitation across multiple settings and populations. Her expertise is in treating adults with neurological illness/injury. She is an assistant professor at Oregon Health and Sciences University, where she conducts research as part of the Renew Lab, reclaiming expressive knowledge in elders with communication difficulties. Renew projects research ways that augmentative and alternative communication AAC can support adults with degenerative neurological disease as they experience complex communication impairments. Ms. Mooney is an assistant clinical professor at Portland State University in the Speech and Hearing Sciences Department, where she teaches cognitive rehabilitation and supervises adult cognitive rehabilitation clinic with graduate students. And with that, I will turn it over to her, and with that I will turn it over to her.
Okay, Kevin, thank you very much for that nice introduction, and everybody, thank you for connecting to what I consider a very important and exciting topic. Tonight, I'm excited to be able to present to you something that's near and dear to my heart, and that is how we instruct individuals in using different compensatory or communication strategies. So the objectives tonight that I hope that you leave with is that by the end of our presentation, you will be able to understand and describe the 6 essential principles of systematic instruction, that you can identify at least 3 characteristics of the person, the program, or the instruction that really support intervention success. That you can also identify the different stages of your learner and know how to optimize those for intervention in teaching AAC. And that in the end, you'll be able to describe effective instructional techniques to be able to make communication effective. So here's our schedule tonight. We have a lot of information, as we always do, to share, and we're going to get through it as rapidly as possible to leave time for questions. Again, as Kevin said, if we're not able to get to all of the questions, I'll be very happy to respond to questions by email afterwards. So we're going to start by just making sure that we're all on the same page with AAC. Then we're going to talk a little bit about thinking and cognition, go into variables that do support intervention or instruction success, spend the majority of our time on systematic instruction, talk about stages of learning, and then end with a case example. So I always like to start any talk that I give with a few very important, what I consider takeaways, so that if you end up falling asleep, if you're on the East Coast, that at least you have these things in your mind. That really, and I'm sure that we all feel this way, that communication supports without training is not supportive. I want you to really know and be convinced that systematic instruction is effective, that it takes a lot of time and effort on our parts as clinicians initially, but it's really worth it. And I really want to encourage people to plan for that systematic instruction and plan to have your clients or patients really see you multiple times in order for that instruction to be effective. We really want to make sure that we're training to mastery. Instead of just giving people suggestions and showing them and telling them how to do things, we really want to demand that repeat demonstration on multiple trials and get them to mastery. And then, of course, from the moment we do that initial assessment, we want to be planning for and practicing generalization, so that you can hear on follow-up visits, oh yeah, I'm using this AAC app, or I'm using this SGD, and it's very effective for me. All right, so setting the stage. I'm going to be honest and tell everybody that I've only really come to AAC in about the past 8 years. Before that, my entire career has been in cognitive rehabilitation with adults with neurological illness or injury. And so it was actually really easy for me to make the transition, because I can just see so many similarities in teaching compensatory cognitive supports and in training compensatory communication supports. So in our field, we use lots of different names to refer to AAC, and I will use all of these different terms probably this evening in my talk. And because I'm from Portland, we use the rose there, the Rose City icon or photo. All right, so this, I'm going to whip through this because you all know this much better than me. So when we think about AAC, we're going to think about the 5 W's and who. These are the adults that rely, in this course tonight, adults who rely on AAC and their partners and facilitators, AAC clinicians, including AAC specialists, but also speech pathologists that are just in private practice. As you know, there's just many and multiple considerations when we're talking about the person who uses AAC, from all of their individual characteristics to their partners, what modes, the demands of the communication environment, and of course the AAC tool of choice. So today, I'm really going to be talking about, when we think about AAC competencies, we're going to be really talking about ensuring success in operational competence. So when we talk about the who, of course, we think about that person, and first and foremost, besides their language assessment, we'll be conducting a great cognitive assessment. We have adult children that bring their clients to us that say things like, I bought her this iPad, but gosh, she just can't seem to find the correct page ever on the iPad. So in my mind, of course, we go right to, why can't she find the correct page? What are her cognitive skills? Of course, we want to look at sensory, vision and hearing and fine motor abilities. What is the person's previous experience with technology, their partners, and the motivation? again, I'm not going to spend any time on these because you guys know all of this. You know about considerations of partners and modes. Now I'm going to ask you to think about instruction when you think about who am I training? They're a learner as well. And what mode am I training? What are the cognitive impacts of that? Where am I training? To what environment do I need to train to? And again, how does my instruction differ based on the end goal or the end environment where this person needs to function? And then when. So of course, we can all agree on that the ultimate goal is to enhance participation in communicative life. We all believe that communication is a collaborative enterprise. And we all believe that allowing people to have communication support is really truly an ethical issue, and it's our responsibility as the clinicians to identify and establish any method, strategy, or resource to help a person to communicate more successfully. So we're all on the same page with AAC, and now let's talk about thinking. So when we think about thinking, this is a slide that is framed and in my office. All of my students have it and printed out, and we just have it available to us at each and every opportunity when we're communicating with our patients, because we want them to think about their thinking. We want them to know how their thinking affects their ability to learn and use different AAC apps or devices. So briefly, we know that all thinking skills have a foundation of energy. And as speech and language pathologists, we're not going to be able to solve all of their different energy problems, but we do want to help identify them and then get them referred to the person that can. So we think about things that might take away somebody's energy and thus affect their cognition or their ability to learn and use AAC. Things that might take away energy are pain, low mood or depression, anxiety. Lots of different medications that people are on cause slowed thinking processes. So we need to think about those. Of course, sleep quality affects our energy, and chronic illness can affect our energy as well. So right above energy, when we think about cognition, is speed of information processing, and we can conceptualize that as the speed with which a person's brain processes both visual information and auditory information. Of course, I would never talk with a patient that had traumatic brain injury at the rate that I'm speaking right now, because it's very rapid. And we know that moving up our triangle here, that if I'm speaking so rapidly, somebody may not be able to attend to what I am saying. And if they can't attend to it, focus their attention, they're not going to be able to store it. If they don't store it, it's not there for recall, which is what people need when using AAC. We're of course going to be cognizant of how the brain processes the visual information that it sees. We know that thinking skills entail all different types of memory, and we can think about memory in terms of being time-based. Is it immediate memory? Is it long-term memory? We can think about it being stimuli-based. Is it visual memory? Is it auditory memory? Is it motor memory? And then we think about new learning. And new learning is with repeated exposure to the same information, does somebody retain that information over time? So very imperative that we know about somebody's new learning capabilities when we're trying to train something that they're going to need to recall repeatedly. And finally, we have executive function, and that is that whole set of skills that looks at the ability to plan, problem solve, choose a course of action, initiate a plan, monitor performance, be able to look for errors, find errors, correct them to come to task resolution. Here's just a repetition of factors which make cognition or communication skills worse. And again, I raise this in the context of you keeping this in mind as you're training or instructing AAC use, thinking about these things for your learner. So how does cognitive status impact instruction and AAC use? These are just some examples. So we hear clinicians say many times, oh, the patient's non-compliant, or I showed them how to use it, but they just don't use it. Or I was just on the phone with an expert clinician yesterday, and we were talking about an AAC app, and I heard her say to a colleague, gosh, yeah, you know, we tried that once or twice, but it just never worked. And so I think, oh, that's why it didn't work, because we just tried it once or twice. And that could be in relation to any of these cognitive areas. Did they have poor speed of information processing? Well, they might not track your instructions. You can pick this up because they're nodding their head or they're just saying, but they never really ask questions or stop and request clarification on something. If somebody doesn't have the attention skills, they may lose their place. You may notice that you can't hold their focus of attention. They're easily distracted. Or they may have difficulty switching gears. Well, guess what? When we're having them switch through multiple pages of an app or on an SGD, multiple layers, we need them to have excellent alternating attention. So we need to train that during our instruction. In terms of memory, of course, it could be considered poor follow through, or when they go to, when we request that they repeat our instruction, they're unable to do that. New learning, again, you may find yourself repeating the same thing multiple times and still not being able to have them give efficient or accurate repeat demonstration. And so that's going to change how you give your instruction. And then finally, with executive function, we may see something as large as just poor initiation of trying an app or of loading photos or messages into an SGD, or we may see it as narrowly focused as just inability to initiate within that app or within that SGD. We could also see executive function exhibit as inability to problem solve solutions when they get lost within an app, or poor error awareness or poor correction. So today I really hope that by the end again of our session that you'll have just gotten a better sense of all of the elements of learning and instruction. And what I like to say is I just want to set up our patients for participation success. So I'm going to think about the environment that I'm teaching them in. I'm going to think about their personal characteristics. I'm going to think about my personal characteristics. Am I slowing my rate of speech? Am I doing my thorough assessment? Do I give myself enough time with this patient so that we can successfully reach their goal? Do I plan for generalization? I'm going to think about the program characteristics and the task, the complexity of the task that I'm trying to train. So now let's talk about variables that support instructional or intervention success. So the personal characteristics, you can see them here, but they include self-efficacy. So really helping a client really believe that they can learn this task, that we can find a way to successfully teach them. Helping give them the locus of control. It's not us telling them they should use this app or telling them we're doing a great assessment and we're finding through our person-centered assessment what's going to be important to me. And everyone may or may not have the pleasure of knowing Dr. Melanie Fried-Oken, but she taught me early on, don't just teach, don't just have the language on their SGD or their app be about medical needs. Have it be about something they're interested in. And so really, again, during your assessment, giving them that locus of control in choosing the language that's going to go on whatever we're teaching, whatever app or SGD we're using. Of course, you need to think about the emotional status of where your client's at. Are they coming to an acute situation or is it chronic? And both of those have different implications. Somebody in acute may not have buy-in, or they may be highly motivated to use something that's going to help them express themselves. Somebody who has a chronic illness may give up, so they may be harder to motivate. So all those things need to be factored in when we think about our instruction, thinking about personal characteristics. Of course, you know that you're considering their disease characteristic, and degenerative certainly has a different profile and trajectory in your instruction than a recent injury. And we've talked about assessing cognitive status and psychosocial status. In terms of program characteristics, we really need to think about some of the elements I'm going to talk about soon with systematic instruction, really that it's necessary to have high rates of practice, high intensity, high repetition. And I think sometimes in our field, we don't do that. We see folks once or twice and then say, hey, go out and try this and then come back in a few months. But really, systematic instruction demands that we see people at a pretty high rate of intensity for that first few weeks until they get to mastery. And then we reduce the frequency that we see them as we're seeing that they're able to maintain a skill set and generalize to different environments and to different communication partners. I'm going to talk about most of these things later, so I'm going to keep moving on in terms of program characteristics. And now we're getting to the meat of today's session. And when we think about the models of instruction, there's the apprentice model, or what we call kind of an observational model. You're just following somebody in what they're doing. It's a very highly uses motor learning. And then there's the trial and error approach, or what we call discovery learning. An example might be learning a new sport. And we really don't want to use trial and error in rehabilitation, because if anyone has any level of cognitive impairment, we don't want them learning from their mistakes. They may not be able to remember how to correctly do that. So we're really going to use systematic instruction. Sometimes I'll be abbreviating that in the slides going forward as SI. So what is systematic instruction? It comes to us from the fields of special education and neuropsychology. It's been applied across many populations. It's evidence-based. It's really an entire comprehensive package of explicit, intentional instructional techniques used to teach or train strategies, facts, or concepts to mastery across populations, including those with cognitive impairment. It has the assumptions that teaching is complex, but that it enables a learner to do something, and that through instruction, a learner's behavior can be changed. Systematic instruction is central to cognitive intervention approaches, especially those that are addressing compensatory techniques. There's much evidence that training rehab therapists, in fact, training physical therapists and occupational therapists as well to use specific instructional techniques is associated with improved outcomes. And we all know too well that in our era of significantly reduced funding for rehab, really it's imperative that we have well-designed and delivered instruction so that we can maximize the time that we do have with our patients, and again, promote positive outcomes and generalization to their home and community environments. So when we think about instruction, we want to think about what is it about the learner that makes him able or unable to learn, and what is it about my instruction that makes him able or unable to learn? So I try and keep this model in my mind. And so this is probably going to sound familiar to you. This I borrowed from Scherer, Solberg, and Tuxtra. And these are what they identify as the key components of training assistive technology for cognition. So doing a cognitive assessment, of course in AAC you would not only do a cognitive but a language assessment. Of course AACs are just masters at doing, AAC practitioners at doing the next two, the needs assessment, and then using feature matching to do system selection, and then trialing whatever system or app that was chosen in different environments. So there's nothing new there for you. So now I'm going to move forward talking about two different things. First of all, the principles of systematic instruction, and then the stages of learning, and then bringing those two together. So the first principle is neuroplasticity, and systematic instruction uses repeated guided practice to stimulate those neural pathway connections so that learning becomes automatic, effortless, and overlearned. So through the high levels of repetition, we are stimulating neurons. And two of my favorite quotes are, neurons that fire together, wire together, and we are trainers of cells. That's better than speech and language pathologists. So neuroplasticity, again, uses repetition, high amounts of practice. You need salience for neuroplasticity to happen, and of course, probably nothing more salient than having somebody's personal lexicon as they're engaging stimuli, and that training using hyperspecificity in training use of this communication app or technology does affect generalization. The second principle of systematic instruction is errorless learning. So we know that errorless learning taps into the non-declarative or procedural memory, and we also know that this is something that's relatively spared in people with cognitive impairment and even late into dementia. And systematic instruction really capitalizes on this strength. We don't want to use trial and error because errors stick, and we don't want those errors to stick. So the goal of errorless learning is to avoid errors during initial skill acquisition. And we'll talk about how when we're training somebody, we just don't allow that error to happen. We simply give the correct answer and move back and have them demonstrate it correctly. And we might be increasing all sorts of cues to get them to be able to demonstrate it correctly, and then reducing cues moving forward. Errorless learning is enhanced by these things. Initially giving sufficient modeling, gradually fading your cues, giving immediate corrective feedback and remodeling, minimizing guessing, and then of course, high amounts of correct practice. Another principle of systematic instruction is distributed practice. So we want to distribute when people need to retrieve and demonstrate their ability to use an app or technology. And we know through the rehabilitation research in cognition that this is truly imperative over over somebody just cramming for something. Massed trials. So we know that spacing out practice trials and encouraging active retrieval does encourage long-term learning. That's why we need more frequent visits and visits that endure for a longer period of time. So I'm not going to spend a lot of time, but one evidence-based validated practice is of distributed practice is spaced retrieval. And spaced retrieval builds on successful recall by increasing delays between intervals. And there's lots of evidence. We have a brand new updated systematic review in 2014 that is endorsed by ASHA, also telling us that use of this distributed practice, spaced retrieval, is very, very helpful for teaching acquisition of compensatory strategies. So I just want to take a minute here and hit home the point of when we're doing spaced retrieval and how that ties into errorless learning. So, for instance, if I taught somebody something at 30 seconds and they give it to me correctly, and then at 1 minute they can say, yep, to get to my photo, I tap start and then I swipe and then I find my photo icon. So they've done that at 1 minute, 2 minutes, and then they give me the wrong demonstration. I'm not going to say to them, no, don't hit there. I'm not going to repeat the no or the incorrect information. I'm simply going to say, oh, this is what you do to find your photo roll. I'm going to then demonstrate and give verbal instructions that are correct and go back to the previous time interval where they were successful. Then increase the interval and move forward. So spaced retrieval not only uses distributed practice, but it also uses errorless learning. Okay, another principle of systematic instruction is having our patients actively retrieve the information. And that's having us stop instruction. Hello? I got a little interruption. I think, okay, that's having us trying to get them to actively recall or tell us the strategies that they're going to use to recall information that we're training. Now, of course, with somebody that is nonverbal, this is going to be extremely challenging. And finally, one of the most important aspects of systematic instruction is engaging people's own metacognition. So they're thinking about their thinking. We want them active and not passive in this learning process. And some of the strategies that we can use as instructors are for them to predict their performance. What do you think is going to be easy about learning this? What do you think is going to be hard? And then asking them to reflect on their performance. And when they're doing either of these things, predicting or reflecting, we want to try and pick up on the way that they describe the app or their SGD or their performance. And we want to use those keywords and phrases to help them maintain those associations. And of course, you've already discussed how remembering how to use this app is important because you did that in your assessment. All right, moving on to stages of learning. There's 4 stages: acquisition, mastery, maintenance, and generalization. And the goal of initial acquisition is to get somebody to mastery. So that's that initial phase of learning or relearning. We then move to maintenance, and the goal of maintenance is extending their learning or their demonstration of what they've learned with an app or the AAC technology to new contexts, new tasks, new communication environments, new communication partners. And then finally, generalization is the goal of that is making sure that that person can retain the demonstrated skill over time and even maintain it when we start to learn then possibly new communication apps. So these are some of the strategies that we as clinicians would implement during each of these stages. During initial acquisition to mastery, we're going to give lots of opportunities, sufficient opportunities with errorless learning and variable practice. We're going to fade our cues and we're going to train to mastery. Of course, during maintenance, we start to distribute that practice over time. And then in generalization, we are programming by having them use their app with different partners with us, or having them or their partners be able to giving them assignments where they can come back and somehow give us very concrete examples of when they were able to demonstrate the skill in different environments or with different partners. So there's 4 steps to systematic instruction. And the first 2 steps are to do a needs assessment and then design the instruction. Step 3 is the instructional delivery, and step 4 is that ongoing assessment and making sure that the instruction had the impact that we want. So step one, again, you all know this, I don't need to spend time on this. You figure out who your learner is. Most importantly, with our AAC apps and our AAC technology, we want to find out what prerequisite information do they need to know. When we design our instruction, of course, again, I think you all know this, you're selecting your meaningful relevant targets. You're breaking down the tasks into component steps. We're going to spend some time on that. You're selecting and sequencing multiple examples or multiple trials. And you're identifying for yourself clear instructional wording. And I find that in teaching new clinicians, sometimes it's helpful for them to have scripts when training a complex set of procedures or a set of procedures that requires multiple steps. And then when you're delivering the instruction, you're going to give sufficient models. You're going to give opportunities for practice and review of steps. You're going to pace your instruction at a rate that your learner can learn. You're going to give them feedback through the cueing hierarchy that you've developed, and you're going to get them to mastery. And then through all of that, you're keeping, over to the right here on your slide, you're keeping in mind all of the principles of systematic instruction. Of course, through any instruction, we want to be assessing how successful am I as an instructor in teaching this skill. So you're going to start your sessions with a brief probe to determine the retention of what was taught previously. Then you're going to focus your treatment based on that probe. And if errors emerge, you're going to isolate that error and you're going to remodel and give practice until that particular step is firm. And then you'll weave that back into the sequence of skills. You're, of course, collecting data and you're analyzing any patterns that you're seeing. This is a really nice handout called the Clinician Self-Assessment of Instruction. And I use this for students, but I always think to myself, boy, this is good for me as a clinician with many years of experience to just check myself. So I'm just going to show you both slides because it's got steps 1 and 2 for design, and then step 3 for delivery, and step 4 for impact. So steps 1 and 2 are just, it's going through everything that we've just gone through. Have you conducted your needs assessment? Does your client have buy-in? Have you clearly defined the nature of the instructional target? Am I attempting to address too many goals or objectives? Am I trying to teach 3 apps at once? How to use the phone app, how to use the contacts and the weather and the maps. Let's train one and let's train it to mastery. Do I prevent errors? Do I chain the steps together? Do I distribute practice over trials, etc.? And then impact step 4, asking yourself, have I assessed maintenance? Have I assessed generalization? Okay, so now we're going to go into our example, and I'm going to try and get through this in 5 minutes and then leave time for questions. So this sample on the left is somebody's functional daily routine. This person, first of all, needs to recognize the situation that if I want to share about my day and I have primary progressive aphasia, and I'm losing access to my lexicon, or I have acute aphasia and I've lost access to my lexicon, but I like to go around my neighborhood and I'm still active in my community, I need photos to support my communication. So if I want to share with another person about what I did during the day, I need photo supports. So they need to locate their device, they need to be able to enter those photo supports into the app. And that's going to take us over to now doing a really detailed skill task analysis of how to enter into an app. And then I need to initiate using this app as support during conversation. So on the left is the big picture, how this affects their day. And on the right is, we're going to go to now the very specific task analysis. So the forms that you're going to see right now come from this textbook, Optimizing Cognitive Rehabilitation, from McKay Solberg and Lynn Turkstra. So this form is called Instructional Planning for External Cognitive Aids. And so we've adapted it today for breaking down, training someone to use the app sounding board on their iPad. So one of my colleagues, Deirdre McLaughlin, filled this out for us today for you to be able to look at here as we go along. So the primary function is to increase participation and sharing personal stories with communication partners. What are the requisite skills? Well, they need to be able to know how to use touchscreen on an iPad, and they also, in order to use Sounding Board, need to use the photo app. We have short-term and long-term goals identified. Okay, so moving on. So what am I teaching the client to do? Well, first I'm doing my task analysis. I've got to teach them how to take a photograph using their iOS photo app. I need to teach them how to create a new communication board in Sounding Board. They need to know how to create and program buttons and then save. This plan is customized to our client. I've identified the context and antecedents that are going to be necessary for this instruction to be successful. And we're going to measure progress towards long-term goals. Now, I want to say here that I'm giving a really detailed example today. You may have a client that knows already how to take the photo, so you don't have to include that in your training, obviously. You will start based on your assessment, where they are. When and how will I teach this instructional target? Well, I'm going to do it 2 times a week for 60 minutes. And I know heads are rolling right now because no one gets to see their clients that often, but this is the ideal, that we have, according to the principles of systematic instruction, the frequency and repetition that we know is necessary for instruction to be successful. We want to make sure that there's opportunity for sufficient practice within and across sessions. Of course, we're listing our materials here, what we need. And we've outlined the progress for progressing from modeling to distributed practice. We've identified where the tool is going to be used, who's going to support training besides ourselves. We've described the context, and we've written our plan to train, support people in this environment. I know it's very, very hard to see this slide. I'm going to try and make it bigger. I did. So when we look at the goal here of iPad with Sounding Board, and we look at all of the steps, there are 25 steps for somebody to be able to make a 4 to 6 picture board in Sounding Board. And so it's no wonder when people say, oh, they didn't use the app, or oh, she tried it, but she didn't really like it. Well, it's complicated, and it might not seem complicated to us, but with somebody with complex communication needs or somebody with any level of cognitive impairment, it's complicated. So it's essential that we do a really good task analysis and find out where that person is, and then be able to track, can they do each of these steps? And when they can't do the step, to stop, go back, provide modeling. Don't let errors happen during this initial acquisition. Have them re-demonstrate and then move on, and then of course chain those steps and then do a cumulative review to see that they can successfully utilize that app. So here's the first step. Step number 1, after we've they can show us that they can turn on their phone. Step number 1 is effectively locate the Sounding Board app. Step number 2 on our task analysis is press the plus add board button. Step number 3, name the board. Now select an image. That's when you press select an image on sounding board, it will take you to the option of using your camera roll. We now select the image we want there. We can add different elements through sounding board. We could add voice output if we would like. We can add our next image. All of these steps have been broken down into that task analysis for your initial assessment. Then you find out where their problems are, and we go back and we retrain. And then finally, you come to they're being able to tell you, I went on a walk today from my house down the street, and you can see here that the leaves are starting to change. I saw so many different reds and yellows, and there was our grandson's bike. He came over for a visit, and then he and I ended up going on a walk down the lane. So now this person has all of these photos to support his communication in daily life. So this series of forms are called 7 points, and it's a therapist's ability to take data during sessions. Of course, you're going to modify this for use in your setting, but you really here can get probe data from up to 5 sessions at a time on those elements from your task analysis that the person needed repetitive systematic instruction on. And then there's other data collection forms for you to be able to collect data on maintenance and generalization. Okay, we are getting close to the end here. I wanted to show you one other very quick example of task analysis. This is an app that we used in our lab for research called CoChat. Again, all we did was take the operations that are necessary to use CoChat, and we just made a list. Can they demonstrate how to use the iPad? Can they press the home button, then the arrow to slide open, find the icon, find their initials, press photo, take the photo, etc. So putting the time up front to do this really thorough task analysis, find out where their problems are in being able to complete the sequence, do that excellent assessment, and then give multiple options for repeated practice of successful demonstration is going to be effective in the long run for training AAC. I'd like to acknowledge the funders here at our lab at OHSU, Renew. And now I am available for questions.
Conclusion. Thank you, Aimee, for this informative hour. If you have any questions, please type them in the questions pane and to answer people ask questions about the slides slides. They will be available on the USAC.org webinar page starting tomorrow, September 25th, 2018. If you have any questions, please type them in the questions pane, and to answer people's questions about the slides, they will be available on the usac.org webinar page starting tomorrow. Aimee.
Yeah.
Marianne asks, how do you match cognitive demands of a app or STD with the Aimee. Marianne asks, how do you match cognitive demands of the app or STD with the cognitive skills of the user? Aimee. Marianne asks, how do you match cognitive demands of the app or STD with the cognitive skills of the user?
Marianne, that is such a fantastic question, and something, so I think that historically in the person to user technology match, we have identified a person's cognitive functioning. So we can say, oh, this person has poor selective and alternating attention, or we can say this person just really can't demonstrate the ability to get back on track when they've lost their way within a page set on the SGD. But we haven't really looked at what the SGD is demanding from the user and what the features are demanding. So in looking at display, for example, we could say, gosh, let's only have single page displays because we know those don't require alternating attention. But when we go to multiple page displays, those require alternating attention, and that's going to be very difficult for this person who relies on AAC. I'm not saying that person can never use multiple page displays, but initially, let's make sure that the technology isn't demanding something that they're not capable of. Let's identify that, and then let's train to that. So really important moving forward for AAC practitioners to think about what does the feature of the app or the SGD demand from my user from a cognitive standpoint, whether it's memory or attention or executive function.
Thank you. And next, Tiffany. Tiffany asks, have you experienced with adults how who are not speaking to due to a developmental condition and now are experience with adults who are non-speaking due to a developmental condition and now are we learning to use a able to identify goals for themselves because nobody asked them before. Thank you. And next, Tiffany asks, have you experience with adults who are non-speaking due to a developmental condition and now are learning to use the SGD and they are less able to identify goals for themselves because nobody asked them before?
Gosh, Tiffany, that sounds like a very complicated situation, and I have not had experience with adults with developmental delay. I've had experience working with adults who are non-speaking and need to learn to use AAC technology again. So I'm hearing a lot of different points there. So one is the last thing that you mentioned, and that is about the goals. So I think going back to what I mentioned earlier, for us as a clinician to try and figure out what is important to them to communicate. So I can tell a story about an adult that lost all ability to communicate secondary to a brainstem stroke, and his initially hospital-based speech and language pathologists were trying to focus on his basic needs. Did he have pain? Did he not have pain? When we saw him later in his home environment, his father was awesome at helping identify for us to try and get a yes-no response, that maybe the target needed to be pictures of young ladies in bars. So whether or not I felt that was appropriate or not, his goal to communicate, the goal that we were trying to use to inspire him to communicate or to get a yes-no response was something as a young man that was interesting to him, and that was pictures of young women. So trying to find where that person is now and what of anything can be of interest to them in setting a very basic goal. The second thing I would say is if they're just learning to use an SGD after being non-speaking, that you really need to look at the complexity of the tasks and break it down to very, very simple tasks. And then after they can master one steps or two steps, then adding a third or a fourth. So adding on and chaining as they become successful at doing one thing. Maybe they're able to choose one target and then to chain that to something else. And then just really thinking about how you would modify your instruction in terms of modeling and cueing. And you might be cueing.
That was Melody that asked the sorry.
That's okay, Kevin. I
was September 25th, 2018. Hey. Sorry, that was a mission. Miss. Hit.
That's okay. I think I was finishing.
Okay. We need to finish up and we will email those who I didn't get to with my slow typing. Sorry, that was a mishit. I didn't. Okay, we need to finish up and we will email those who I didn't get to with my slow typing.
That's great, Kevin. Thank you.
Thank you all for your participation this evening. Please complete the evaluation that you will find at www.isaaconline.org/English/news/WEBINARS. We are especially interested in your suggestions for future topics. Join the USAC to make sure you get the inside scoop on AAC in the United States. Don't forget, next month is AAC Awareness Month. Check out the newly designed USAC.org over the next few weeks for cool information that we are going to post, including next month's webinar by Dr. Tracy Reckensberger. Franklin, I know I'm done, and thank you.
Thank you, Kevin.
Again.
Thank you, Kevin, and thank you, Aimee, very much. And thank you, everyone, for being in attendance this evening. Have a good night, everyone.